Welcome back to the Deep Dive, the show where we take a mountain of information and distill it into the crucial insights you need.
Great to be here.
Today, we're plunging into a topic that's, well, both a marvel of modern medicine and a really persistent, often devastating challenge. Periprosthetic joint infections, or PJI.
Right.
Joint replacements have truly transformed lives, haven't they? Offering incredible mobility, renewed freedom.
Absolutely life-changing for so many.
But this success can, unfortunately, be profoundly undermined by PJI. So this deep dive is really aimed at you, our medical professional listeners.
Huh.
We want to unravel the complexities of PJI, offering insights that are hopefully crucial for daily practice and for optimizing patient outcomes.
That's precisely it. And, periprosthetic joint infection is a clinical entity that really stands apart.
How so?
Well, it's fundamentally different from the infections that we typically see in native bones or joints.
Sure.
What's fascinating here, from a mechanistic standpoint, is just how little it takes for PJI to actually take hold. A minimal microbial burden, that's really all that's required to initiate it.
Minimal. That sounds counterintuitive.
It does, but these organisms, often from our own skin or maybe even distant sites in the body, they have this remarkable ability. They stick really tenaciously to the surfaces of the implant components.
The artificial joint itself.
Exactly. And then they form these complex communities. We call them biofilms.
Biofilms. Okay, that word immediately makes me think of something incredibly difficult to penetrate. What is it about biofilms that makes them such a huge challenge in PJI?
It's a critical question. Biofilms are, well, they're essentially a protective slime layer, a self-produced matrix that encases these microbial colonies.
It's like a shield.
Think of it like a fortress, yeah.
Yeah.
And within this fortress, the bacteria, or sometimes fungi, are notoriously resistant to a whole range of antimicrobial agents.
So antibiotics don't work as well.
Not nearly as well. You might need concentrations hundreds, even thousands of times higher than what works against free-floating bacteria.
Wow.
And maybe even more critically, they're incredibly adept at hiding from our own innate immune defenses.
Hiding? How?
Our immune cells, like phagocytes, they really struggle to penetrate this matrix. Plus, the organisms inside are often in a sort of dormant metabolic state, making them less susceptible to how our immune system usually clears infections.
So double protection.
Exactly. It's this dual protection from antibiotics and from the body's own defenses that makes PJI so exceptionally difficult to treat.
And so persistent.
And so persistent, yes. The offending microorganisms, they typically come from the patient's own skin flora, maybe introduced during surgery, or they can seed the implant later, hematogenously from somewhere else, like a UTI.
Or even from nearby tissues.
Or direct inoculation from adjacent infected tissues, absolutely.
Right.
Understanding this unique pathophysiology is really foundational to grasping the enormity of the PJI challenge.
That immediately highlights how, well, sneaky and persistent these infections can be. And it's not just an isolated problem, is it? We're talking about something that's escalating, impacting orthopedic practice and beyond.
Absolutely. The scale of PJI isn't just growing, it's rapidly becoming a top-tier challenge in orthopedics.
How big are we talking?
Well, if you look at the epidemiology, population-based studies show a clear and pretty concerning rise in incidence. For knee PJI, for instance, the incidence goes from about 0.8% at 1 year post-op,
Okay.
up to 2.0% by the 15-year mark.
15 years later.
15 years. And for hip PJI, it's a similar story. Increases from 0.5% at 1 year to 1.4% at 15 years.
So this isn't just a short-term surgical risk.
Not at all. The crucial insight here is that PJI is a persistent, lifelong threat to that patient and the implant. It demands long-term vigilance.
Professor, that's not just a statistic. That feels like a paradigm shift in orthopedic practice. It signals a fundamental change in what we're primarily fighting in revision surgery. What's the biggest implication of PJI becoming the #1 reason for reoperation?
That's a critical observation, and the implication is profound. PJI has now, really for the first time, surpassed polyethylene wear as the main reason for revision arthroplasty.
Wow. So it's not the plastic wearing out anymore.
It's not primarily the plastic wear anymore, and that's a huge shift because polyethylene wear, while it's a problem, is largely a mechanical issue.
Right. You replace the liner.
Sort of. But PJI, that's a complex biological problem. It often needs multidisciplinary teams, long antibiotic courses, multiple really morbid surgeries.
It sounds much harder to fix.
Much harder. This shift demands that we prioritize prevention and early aggressive diagnosis of infection even more intensely, because the alternative is a far more complex and costly battle for both the patient and the healthcare system.
So it underscores why every medical professional, not just orthosurgeons, needs to be really aware of PJI.
Absolute. Primary care, infectious disease specialists, everyone.
And speaking of cost, the economic strain must be just enormous given the complexity you're describing. It's not just a clinical challenge, it's a massive economic one too.
The economic strain is, well, it's staggering, and arguably one of the most pressing parts of the PGI crisis.
Do we have figures on that?
We do. To give you some concrete numbers, the overall cost to the American healthcare system for treating PGI was estimated around $566 million back in 2009.
Okay, a decade and a half ago.
Exactly.
Yeah.
That figure was projected to hit an alarming $1.62 billion in 2020. Billion. And frankly, even those numbers are likely underestimates. They mainly cover immediate hospital costs, not all the other direct and indirect expenses.
Like rehab, home care.
Right. More recent estimates paint an even starker picture. Hospital expenditure per PGI episode is roughly $89,000 for hip infections and $116,000 for knee infections. Per episode. And projections suggest that for the U.S., the estimated annual total could swell to $1.85 billion by 2030.
That's incredible.
The crucial insight here is that PGI is rapidly escalating from a clinical challenge to a major healthcare economic crisis. It forces us to fundamentally rethink resource allocation and prevention, not just for patient well-being, but for the financial sustainability of our healthcare systems.
Those numbers are a real wake-up call. The ripple effect goes way beyond the individual patient. And the cost of the revision surgery itself is substantially higher, too, isn't it?
It is, dramatically so. The cost of revision surgery for PJI is significantly higher than for non-infectious reasons like that polyethylene where we mentioned.
How much high?
For a debridement and retention, or DEAR procedure, it's about 3 times the cost of the primary implantation.
3 times.
For one-stage exchanges, it's 3.4 times higher. And for two-stage exchanges, which are often the most effective but also the most involved,
Right.
it could be up to 6 times higher than the initial surgery cost.
6 times.
And that doesn't even touch the indirect societal costs. Lost productivity, prolonged immobility, need for home care, the burden of long-term antibiotics.
And reimbursement often doesn't cover it.
That's another key issue. Current Medicare reimbursement rates for PGI management are widely seen as insufficient. They really need revision. This isn't just a financial detail. It impacts patient access, especially for underserved populations, and strains institutions absorbing these higher, unreimbursed costs.
It's a really complex web, clinical, economic, societal challenges all intertwined. So with such a huge impact, proactively identifying patients at higher risk becomes absolutely paramount. What are the diverse factors that contribute to PJI, and how do we start categorizing them?
That's an excellent point. Identifying these patients is a cornerstone of prevention. We can break down risk factors into a few broad groups. There are the preoperative and host-related factors, basically the patient's overall health and history.
Okay.
And then there are surgery-related and post-operative factors.
Let's start with the host factors. What are the big ones?
Well, starting with preoperative and host-related elements. A history of prior surgery at that specific joint site is a big one.
Scar tissue, altered anatomy.
Exactly. Also, current bacteremia, or sepsis, obviously, or a previous or active infection right at the surgical site. Those are significant red flags. Any previous hardware or surgery creates scar tissue, alters local anatomy, potentially compromises blood flow, makes it easier for bacteria to set up shop.
Makes sense.
What's particularly concerning is that patients with a history of multiple arthroplasties, especially if they've had a prior PJI in any joint,
Anywhere in their body.
anywhere, they might face up to a 20% risk of another PJI, either synchronously at the same time in another joint or metachronously appearing later.
20%, that's incredibly high.
It is. It highlights how once a patient has had PJI, they are forever in a higher risk category. Requires lifelong awareness.
That's a really important point about patient history. Beyond those historical elements, what about the critical modifiable risk factors? Things that as clinicians we can actively intervene on to make a difference.
Precisely. The modifiable risk factors, well, they represent our greatest opportunity for intervention.
Like what?
These include current tobacco use. Smoking profoundly increases the risk of wound problems and infection after surgery.
How does smoking do that?
Nicotine causes vasoconstriction. It impairs blood flow and oxygen delivery to the surgical site, which is vital for healing and for immune function.
Okay. What else?
Excessive alcohol use, intravenous drug use, poor oral hygiene, all significant. They can compromise systemic health and introduce pathogens. Malnutrition, especially protein deficiency, impairs immune response and wound healing.
And diabetes?
Critically, yes. Poor preoperative glycemic control, particularly in diabetic patients, is a major, often overlooked factor.
Why is blood sugar so important here?
High blood sugar levels impair neutrophil function. Those are key immune cells. It also compromises microcirculation and increases the risk of surgical site complications. Controlling blood sugars, both before and after surgery, significantly improves wound healing and treatment success.
So getting that HbA1c down is crucial.
Absolutely crucial. Below 7% is the general target. Obesity is another major modifiable risk factor. Patients with a BMI over 40 are at significantly increased risk.
Why obesity specifically?
Largely due to increased soft tissue bulk, which can lead to larger dead spaces after surgery, impaired vascularity in fatty tissue, and sometimes more difficulty with surgical exposure and closure. Also, things like intra-articular injections, steroids, hyaluronic acid, anesthetics within 3 months before arthroplasty also increase risk.
Injections into the joint?
Yes, likely by transiently suppressing local immune responses or potentially providing a route for pathogen introduction. The key takeaway here is simple but powerful. Patient optimization before surgery is just as crucial as the surgery itself.
That's a comprehensive list of modifiable factors we can really target. Are there any emerging insights into non-modifiable factors, maybe even a genetic link we should know about?
Yes, the field is always evolving, and there is emerging data suggesting a possible genetic component.
Really? Like a family history?
Exactly. Studies have indicated an increased risk of PJI in patients who have a first or second-degree relative with a history of PJI. And this holds even after adjusting for socioeconomic status.
So it's not just environment.
It points toward a genetic component, perhaps related to variations in immune response genes. Those specific genes haven't been definitively pinned down yet. It's a fascinating area of research that could, one day, lead to genetic screening to better identify high-risk individuals.
Interesting.
And beyond genetics, there's another finding. Patients with Medicaid as their primary insurer show an elevated PJI risk, even when you adjust for things like education and household income.
That's concerning. Why might that be?
The reasons aren't fully understood. It's a concerning disparity that highlights the complex interplay of socioeconomic factors and healthcare outcomes. It might point to issues of access to quality preoperative optimization, or maybe different health behaviors influenced by broader societal factors. It just underscores that PJI risk isn't purely biological.
That's certainly something to watch as research progresses, pointing to those systemic factors. Now, beyond these individual characteristics, how do underlying medical conditions, especially those causing immunosuppression, impact PJI risk?
Well, medical comorbidities that result in immunosuppression markedly increase PJI risk. Simply put, a compromised immune system struggles to fight off even low levels of bacterial contamination.
Makes sense. What conditions are we talking about?
This includes conditions like poorly controlled diabetes, which we just discussed. Also, acute liver injury or chronic kidney disease both can impair immune function and overall physiological reserve.
Okay.
Infection with HIV, obviously, significantly elevates risk due to generalized immune suppression. And then you have inflammatory arthropathies, like rheumatoid arthritis.
Right, the conditions people often get joint replacements for.
Exactly. They inherently involve systemic inflammation, and the very medications used to manage them often contribute to immunosuppression.
Like steroids or DARNs.
Precisely. The use of immunosuppressant or immune-modifying medications like systemic corticosteroids or disease-modifying antirheumatic drugs, DMARDs, contributes significantly to this risk by dampening the body's natural defenses.
And for our medical audience, managing those DMARDs around surgery is particularly tricky, isn't it?
Yeah.
What are the current recommendations?
It's a critical balancing act, absolutely. Perioperative management of DMARDs needs careful consideration. You're often balancing the risk of infection against the risk of flaring the underlying rheumatic disease, which can be debilitating.
So what's the general guidance?
Both the American College of Rheumatology and the British Society for Rheumatology recommend withholding tumor necrosis factor alpha inhibitors. Those are powerful biologic agents around the time of arthroplasty or revision.
Because they're strongly immunosuppressive.
Exactly. The concern is that their potent effect could increase infection risk. While it should always be individualized, ideally with a rheumatologist involved, one common strategy for biologic DMARDs is to withhold them for one cycle before surgery and then resume them 1 or 2 weeks after. This lets the drug clear the system a bit.
And non-biologics, like methotrexate.
Non-biologic DMARDs, which are generally less immunosuppressive, may often be continued, though methotrexate might be withheld if there are specific concerns about wound healing.
And if someone is being treated for an existing PJI.
Right. For patients undergoing treatment for an established PJI, weekly methotrexate and biologic DMARDs should generally be withheld for 1 or 2 therapy cycles before that surgery to minimize any impediment to clearing the infection.
When can they restart them after PJI treatment?
That depends heavily on the surgical strategy. With a 2-stage exchange, you'd typically hold them until the incision is completely healed after the 2nd stage.
Right. Ensure the site is robust.
Exactly. For DARE, or a 1-stage exchange, a common approach is to restart them once the patient is on suppressive antimicrobial therapy after the initial main course, as the acute infection risk has hopefully subsided.
But it's complex.
It is. And you have to remember, patients with active rheumatologic disease might need bridging with corticosteroids while off their DMARDs, which can partly negate the infection benefit of stopping the DMARD. It highlights the complexity and the need for more research to find the truly optimal strategies.
That's a crucial point for clinicians, balancing those competing risks. Moving from patient factors, let's talk about the surgery itself. What procedure-related or post-operative factors influence PJI risk?
Surgery-related factors play a huge role, often reflecting the direct trauma and exposure involved. For instance, an extended surgical time, anything over 90 minutes, significantly increases PJI risk.
Longer time equals more risk.
Yes, there's a reported 9% increase in risk for each additional 15-minute increment.
Why is that? Just longer exposure?
It's not just about longer exposure to the OR environment, though that's part of it. Longer surgeries often mean more complex cases, more tissue handling, increased blood loss, maybe greater surgeon fatigue, all increase the opportunity for contamination and can compromise local defenses.
And the complexity of the surgery itself matters.
Definitely. Addressing significant deformities like severe varus or valgus in a knee or dysplasia in a hip means more extensive dissection, longer times, potentially larger dead spaces left after closure, all conducive to infection.
What about cemented versus uncemented joints? Does that make a difference?
Interestingly, while older data once suggested some types were more prone to infection, large modern studies haven't found a significant difference in infection rates between cemented and uncemented arthroplasties overall.
Okay.
However, cemented arthroplasties do offer that theoretical advantage of allowing local antibiotic delivery through the bone cement itself, which can be really useful in PJI management, as we'll discuss.
So even the experience level of the facility or the surgeon can make a difference. That sounds like a clear argument for specialized centers.
It is, absolutely.
Yeah.
Patients having surgery in low-volume facilities or by surgeons with less experience are at an increased risk of PJI. It highlights the importance of specialized centers and experienced teams, not just for the surgery itself, but for having robust infection prevention protocols, vigilant post-op care, and the expertise to recognize and manage complications quickly. High-volume centers often benefit from standardization, dedicated resources, and cumulative experience.
And what about issues right after surgery? Do immediate post-op complications increase the risk?
They certainly do. That post-operative period is a vulnerable time. Developing a hematoma, a blood collection, or a seroma clear fluid collection, or wound dehiscence, where the wound edges separate,
Right.
are all directly linked to increased PJI risk. These fluid collections are like an ideal culture medium for bacteria introduced during surgery or arriving later via the bloodstream.
And they compromise healing.
Exactly. A hematoma also compromises local tissue perfusion and immune cell access. Interestingly, post-op heart attack or atrial fibrillation have also been statistically linked to higher infection risk.
Really? Why would that be?
Possibly due to aggressive anticoagulation needed for those events leading to subclinical hematomas, or maybe the systemic inflammatory response following the cardiac event itself.
Blood transfusions and infections elsewhere also come to mind. How do they fit in?
Both are significant factors. Allogeneic blood transfusion, getting blood from a donor, is associated with an increased risk of surgical site infection and PJI.
Why donor blood specifically?
The theory is immunomodulation. Transfusions might temporarily suppress the recipient's immune system, making them more vulnerable. In contrast, autologous transfusion, receiving your own pre-donated blood, doesn't seem to carry the same risk.
And infections at other sites, like a UTI.
Yes, a perioperative infection at a distant site, say a UTI or a respiratory infection, is strongly associated with increased PJI risk.
How? Bacteria travel.
Presumably through transient bacteremia, bacteria from the distant infection travel through the bloodstream and seed the new implant. Animal models support this, showing less bacteremia is needed to cause infection right after surgery compared to weeks later. But here's a critical distinction. Asymptomatic pyuria or bacteriuria, just having white cells or bacteria in the urine without actual infection symptoms, has not been consistently linked to PJI.
So routine urine screening might not be needed.
It suggests that routine preoperative screening by urinalysis for asymptomatic patients may not actually be beneficial. It could lead to unnecessary costs, antibiotic exposure, and surgical delays without improving outcomes.
So focus on symptoms.
Right. A careful clinical evaluation for historical signs or symptoms of a UTI at the preoperative visit is advised, along with prompt treatment of any symptomatic infections.
That's a nuanced but important distinction for practice. I know there are also composite risk scores designed to help quantify all this risk. Can you touch on those briefly? Are they useful?
Indeed. Composite risk scores are valuable tools. They try to aggregate multiple risk factors into a single variable, helping clinicians identify patients who might need enhanced prevention or closer monitoring.
Like which scores?
The National Nosocomial Infection Surveillance, or NNIS, System Surgical Score is one example. It includes procedure length, the ASA score that reflects systemic disease burden, and surgical wound classification.
And does it predict PJI?
One large study found the highest NNIS score correlated with a 5-fold increased odds of infection. An elevated ASA score alone has also been consistently linked to increased risk.
Any others?
There's the Mayo PJI score. It's not fully validated everywhere yet,
Right.
but it offers a numerical prediction based on factors like BMI, prior surgery, immunosuppression, ASA score, procedure duration, assigning points to each.
So how should clinicians use these?
The key takeaway is that these scores, even if not universally validated specifically for PJI, can definitely help flag high-risk individuals at the time of surgery. This allows for more targeted preoperative optimization and better patient counseling. They help shift us from being reactive to being proactive.
Okay, so we've identified the enormous burden and the varied risk factors. The natural next step for us as clinicians is prevention. What are the most impactful, actionable strategies we can deploy to shield our patients from PJI?
That's where we move from understanding to acting, and prevention is always paramount. The foundational importance of optimizing those modifiable risk factors before surgery cannot be overstated
We keep coming back to that.
because it's crucial. This includes aggressive smoking cessation. We talked about how tobacco impairs vascularity and immune function, meticulous blood glucose control in diabetics, aiming for that HbA1c below 7%. It improves healing and optimizes the patient's metabolic state for recovery.
And treating other infections first.
Absolutely. Diagnosing and thoroughly managing any existing infections elsewhere before surgery is essential to prevent that hematogenous seeding. In general, it's about careful, thoughtful surgery timed precisely to minimize the impact of a patient's underlying risks. And for patients on DRs, as we discussed, that perioperative management needs coordination with rheumatology, acknowledging we're still refining optimal strategies.
Beyond optimizing the patient, what about the surgical environment itself and the standard prophylactic measures we rely on?
The OR environment and protocols are critical control points. This includes strict surgical site preparation like skin cleansing with chlorhexidine alcohol solutions and meticulously minimizing OR traffic to reduce airborne contaminants.
And antibiotics. Prophylaxis is key, right?
Crucially, for antibiotic prophylaxis, administering cefazolin within 1 hour of the surgical incision, and importantly, before tourniquet inflation, has been definitively shown to reduce PJI incidence.
Timing matters.
Timing is critical. You want high tissue concentration right at the incision moment. And for patients with a self-reported penicillin allergy, remember most can safely get cefazolin unless the reaction was severe, like anaphylaxis or Stevens-Johnson.
So we can often avoid less ideal alternatives.
Exactly. This nuance helps avoid alternative agents that might carry higher PJI risks. For patients known to be colonized with MRSA, a combination of vancomycin and cefazolin is sometimes recommended. Though it's worth noting, alternatives like vancomycin plus clindamycin have shown a higher association with PJI.
How long should prophylaxis continue post-op?
Another important point, based on strong evidence, antimicrobial prophylaxis beyond 24 hours postoperatively doesn't seem to offer additional benefit. It just increases risks like resistance and side effects.
And if you're revising for a known PJI,
Right. For patients undergoing revision for confirmed PJI, perioperative antimicrobials are typically withheld until you get those operative cultures, unless the patient is systemically unwell and needs them immediately. This pause maximizes the chance of getting an accurate microbiological diagnosis, which is vital for targeted treatment later.
what about interventions during the surgery itself? Are there specific practices or things added intraoperatively?
During the surgery, several practices are considered. Recommendations include avoiding overly aggressive anticoagulation for DVT prophylaxis. Aspirin is generally preferred. Over-anticoagulation can lead to hematoma, which we know is a risk factor.
Okay.
The intraoperative use of vancomycin powder directly in the wound remains, well, controversial. Efficacy isn't clear-cut, and some studies even suggest a risk of increasing resistant organisms.
So not standard practice everywhere.
No. However, dilute povidone iodine lavage, basically washing out the surgical field with dilute risk.
Thydidine does appear beneficial in reducing PJI risk, likely by broadly sterilizing the area just before closure. The evidence here keeps evolving, though.
And before the patient even gets to the OR, what about decolonization strategies? Is that routine now?
Preoperative screening for and decolonization of Staphylococcus aureus is strongly advised and increasingly standard practice.
Why S. aureus specifically?
It's a very common culprit in PJI. Meta-analyses consistently show an increased risk of PJI without effective decolonization.
What does decolonization involve? Typically, nasal mupirocin ointment and chlorhexidine body washes for a few days before surgery. The goal is to reduce the bacterial load on the patient's skin and in their nose. Patients should also be advised to cleanse their skin thoroughly before surgery, either with chlorhexidine cloths or just soap and water.
You mentioned antimicrobial-loaded PMMA, the bone cement, earlier. What role does it play at implantation, and is it always beneficial for primary prevention?
Right, antimicrobial-loaded PMMA. Its purpose is multifaceted. It can aim to prevent infection in primary or aseptic revision surgery, or provide additional local antimicrobial therapy during PJI exchange surgeries.
How much antibiotic is in it?
For primary implantation, smaller amounts, maybe 0.5 to 1 gram per 40 grams of cement. Slightly more, 1 to 2 grams, for reimplantation after a PJI exchange.
But does it work for primary prevention?
Well, despite its common use in some places, there's still a lack of definitive high-level evidence supporting its primary prophylactic effectiveness, especially when patients are already getting systemic antibiotics.
So the systemic drugs might be enough?
That's the debate. Some studies show no significant decrease in infection rates with its use for primary prophylaxis. The rationale is that systemic antibiotics might be sufficient, and the local elution from the cement may not add significant benefit in a truly clean prophylactic setting. It's undeniably beneficial in a treatment setting during revision, though. It's complex balancing potential benefit against theoretical resistance risks and cost.
And finally, a long-standing practice that's seen a major rethink. Antibiotic prophylaxis before dental or other procedures for implant patients. What's the current consensus? This is huge for patients.
This is a truly significant shift, yes, and a critical takeaway for every clinician advising these patients. For decades, routine antibiotic prophylaxis before dental procedures was standard for anyone with an orthopedic implant.
I remember those guidelines.
Exactly. But recent, rigorous case control studies have definitively shown there is no increased risk of PJI following either low or high-risk dental procedures for these patients.
No increased risk at all.
No increased risk. And crucially, prophylaxis does not decrease the risk in this context.
So the antibiotics were likely unnecessary.
It appears so. The emphasis now should be on maintaining optimal oral hygiene through routine preventative dental visits, not feeling dental care or relying on unnecessary antibiotics. This empowers patients and cuts down on antibiotic exposure.
That's great news for patients. What about other procedures like scopes?
Similarly, antimicrobial prophylaxis is generally not indicated for urologic or endoscopic GI procedures. However, there's a nuance. One case control study did find a 4-fold increased risk of PJI linked to upper endoscopy with biopsy.
Specifically with biopsy.
Yes, while other endoscopic procedures weren't linked. This highlights that while the general rule is no prophylaxis, the approach still needs some individualization based on the specific procedure and the potential for breaching mucosal barriers, which could lead to bacteremia. It really shows how evidence evolves, changing even long-standing practices.
That's a genuinely significant shift and, frankly, a relief for many patients. Now let's transition. What happens when, despite all these preventative measures, a PJI is suspected? Diagnosing it is famously tricky. often needing real clinical detective work. How do we piece that puzzle together?
You're absolutely right. Diagnosis is often the first major hurdle, and it requires a high index of suspicion. The common signs and symptoms you look for are persistent or new pain, joint swelling or effusion, redness or warmth around the joint, sometimes systemic signs like fever or drainage from the wound.
And what's definitive?
The presence of a sinus tract, basically a channel draining fluid from the joint to the skin surface, communicating directly with the arthroplasty, is considered definitive evidence of PJI. That usually requires immediate surgical intervention.
But short of that.
Short of that, accurately diagnosing PJI requires combining those subjective patient symptoms with objective physical exam findings and detailed lab results. And it's important to remember, the diagnostic threshold for PJI is notably lower than for septic arthritis in a native joint,
Lower threshold, why?
reflecting the unique challenges of biofilm infections on prosthetic material. The limited space around an implant and the nature of biofilms often mean fewer free-floating inflammatory cells. We can't wait for overt signs of sepsis to confirm PJI. Early detection is key.
Can you give us more specifics on the lab tests, especially synovial fluid analysis and serum markers that help piece this together?
Certainly. Synovial fluid analysis is a cornerstone. Specific diagnostic thresholds have been established. For instance, a synovial fluid white blood cell count over 4,200 cells per microliter supports a hip PJI diagnosis.
Okay.
And over 1,700 cells per microliter supports a knee PJI diagnosis.
Those numbers seem quite low compared to native joint infection.
They are, for the reasons we just discussed: limited space, biofilm. A neutrophil predominance over 80% is typical for both hip and knee PJIs, indicating that acute inflammation. For knees specifically, the largest studies suggest thresholds around 1,100 total nucleated cells per microliter and 64% neutrophils.
But even subtle shifts matter.
Exactly. The concept for clinicians is that the diagnostic bar for PJI is significantly lower. We're looking for even subtle changes because early detection is paramount.
Then culturing that fluid.
For synovial fluid culture, best practice is to inoculate it directly into blood culture bottles, right at the time of collection, in the OR or clinic.
Why blood culture bottles?
It significantly increases pathogen recovery and decreases contamination risk compared to traditional plating, provides a more robust diagnosis. We also know culture sensitivity is higher for acute PJI, around 91%, versus chronic PJI, closer to 79%.
Chronic is harder to culture.
As biofilms mature, they become even harder to culture, yes.
What about blood tests? ESR, CRP.
Serum markers like ESR and CRP are useful general indicators of inflammation, but they lack specificity for PJI alone. They can be elevated for many reasons.
Any newer markers? IL-6.
Interleukin-6, IL-6, is interesting. It returns to normal much faster after surgery than CRP, half-life of 15 hours versus CRP 62 hours. Theoretically, it could be useful early post-op. But it's less widely available, and we lack consistent, robust data, so it's not standard practice yet. As for blood cultures, they only pick up an organism in about 25% of PJIs, mostly early ones. And critically, the bug in the blood doesn't always match the bug in the joint.
So local sampling is key.
Essential. Proteomic and genomic diagnostics, like next-gen sequencing, show promise for faster, more precise identification, but they aren't widely used clinically yet either.
It sounds like a puzzle where every piece is crucial, but none are definitive alone. What role does imaging play in this diagnostic process?
Imaging, while useful, also has significant limitations in PJI diagnosis, precisely because findings often mimic aseptic loosening, the non-infectious kind.
So plain X-rays aren't that helpful.
Plain radiography offers limited sensitivity and specificity. It might show effusion, malignment, lucencies around the implant, periosteal reactions, patchy bone loss. But these can also be seen in aseptic loosening.
Because both involve bone remodeling.
Exactly. Both processes involve bone remodeling around the implant, leading to similar radiographic looks. Things like bone resorption or a transcortical sinus tract might strongly suggest PJI, but they aren't always present or definitive.
What about more advanced imaging? PET scans, bone scans.
Advanced imaging like FDG, PET, or technetium bone scans, while more sophisticated, also offer limited standalone diagnostic utility. In specific cases, they might reveal more subtle signs: bony erosion, abscess, sinus tract, loosening not clear on plain films. They're often used as adjuncts when the diagnosis is still murky after clinical and lab workup.
So imaging supports but doesn't drive the diagnosis.
That's the main message, yes.
Given these diagnostic complexities, it seems microbiological diagnosis, identifying the actual bug, is the absolutely critical step to confirm PJI and guide treatment. How do we get that definitive ID?
This is indeed the cornerstone. It dictates our treatment strategy. Intraoperative tissue cultures are absolutely crucial.
Multiple samples.
Multiple samples are essential. Many PJIs are polymicrobial, more than one organism. So you need multiple samples from different sites around the implant to confirm the diagnosis and differentiate real pathogens from contaminants picked up during surgery.
What's the threshold?
Detecting the identical microorganism across 2 or more samples is a key diagnostic criterion. It gives you confidence
And stopping antibiotics beforehand helps.
significantly. Abstaining from antibiotics for at least 2 weeks before tissue culture, whenever possible, enhances the yield. This antibiotic holiday lets any lingering bacteria grow enough to be detected. Even low antibiotic levels can suppress growth and cause false negatives.
What if only one culture is positive?
A single positive culture is often regarded as a contaminant, unless it's a particularly virulent organism like S. aureus or gram-negative rod, or if the same organism is found in another sample type, like synovial fluid or sonicate fluid.
So sending just one tissue sample isn't enough.
Not recommended. Significantly increases the false positive rate. And while a sinus tract is definitive evidence clinically, swabbing the drainage from it is not reliable for microbiological diagnosis. Too many superficial contaminants.
That makes perfect sense. What about sonication of the explanted components? This sounds like a more advanced technique that directly tackles that biofilm challenge.
Sonication is indeed a pivotal diagnostic advancement. It directly targets the biofilm by physically dislodging bacteria from the implant surface.
How does it work?
Protocols have been refined, like at Mayo Clinic, involving vortexing and using special containers to enhance bacterial removal and minimize contamination. This technique has shown higher sensitivity, about 79%, compared to tissue culture at 61%.
Especially useful after antibiotics.
Particularly beneficial then, yes. For patients who got antibiotics within 2 weeks before surgery, sonicate fluid showed 75% sensitivity versus only 45% for tissue culture. It highlights its ability to detect organisms suppressed by antibiotics.
So you basically shake the bacteria off the implant.
In essence, yes. You place the explanted implant in sterile saline and hit it with high-frequency sound waves. These waves create microscopic bubbles that implode, creating forces that disrupt the biofilm and release bacteria into the fluid. Then you culture that fluid.
Is there a specific count needed?
The optimal threshold for significant growth, say 10 CFUs per ml or 200 CFUs per ml with concentration, can vary. It should take into account how virulent the identified bacteria is. A very nasty bug might be significant at a lower count. You also generally avoid using broth media for sonicate cultures because it's hard to distinguish contaminants if you get heavy growth.
And what about molecular diagnostics like PCR? Are they a game changer, especially for tricky cases or hard-to-culture bugs?
Molecular diagnostics, particularly multiplex PCR assays, show significant promise. They offer rapid detection and can identify organisms even when cultures are negative, especially after recent antibiotic use.
Faster and more sensitive.
Potentially. While broad 16S rRNA PCR on fluid or tissue is sensitive, it can pick up DNA from dead bugs or contaminants, leading to lower specificity. Multiplex PCR assays, designed to target the most common PJI pathogens, seem more appropriate for sonicate fluid because they're more specific.
So they're useful when cultures might fail.
They can be especially advantageous then. For instance, in one large study, sonicate fluid PCR was 77% sensitive versus 70% for tissue culture and 73% for sonicate fluid culture. But when patients had received antibiotics, PCR sensitivity jumped to 88% compared to 70% for culture.
Are there downsides to PCR?
There are limitations. Poor lysis, breaking open the bacteria of certain strains, like some S. aureus, can cause false negatives if the DNA isn't released. Host DNA can sometimes interfere too.
So they complement culture, not replace it.
Generally, yes. They're excellent adjunctive tools, especially for fastidious organisms or after antibiotics, but they usually complement rather than replace traditional cultures for the definitive diagnosis right now.
So once we've navigated this complex diagnostic maze and confirmed a PJI, the next huge step is treatment. It's clear this isn't one-size-fits-all, and it often requires a highly collaborative team.
That's absolutely correct. Treating PJI is profoundly complex. In the vast majority of cases, it demands a synergistic combination of aggressive surgery and prolonged medical therapy.
Team effort is key.
Success hinges on a highly collaborative interprofessional team. Ideally, this includes an orthopedic surgeon experienced in these complications, an infectious disease expert to guide antimicrobials, a dietitian for optimal nutrition, a rehabilitation specialist, plus dedicated nurses and pharmacists.
And maybe mental health support?
Increasingly warranted, yes. Given the profound physical, social, and psychological impacts, integrating a psychologist or mental health professional is important. The emotional toll is immense.
What's the first principle of treatment?
A crucial principle. Ideally, withhold antibiotics until after multiple intraoperative specimens are sent for analysis, unless the patient is systemically infected and needs them urgently. This ensures the most accurate pathogen ID for targeted, effective treatment.
How do we even define success when treating PJI? It seems like it would be more than just clearing the infection, given the lifelong implications.
You've hit on a crucial point. Defining treatment success has evolved. A robust definition includes several key elements.
Like what?
Microbiological eradication, the bugs are gone. Clinical eradication, signs and symptoms resolve. Critically, freedom from subsequent surgery for the same infection, avoiding recurrence. And importantly, freedom from mortality related to the PJI.
So it's multifaceted.
It is. This provides a robust standard for evaluating treatments and is often tracked over short-term, 2 years, mid-term, 5 years, and long-term, 10+ years. It also helps educate patients about what recovery truly means and manage expectations. Let's delve into the surgical strategies. What are the main options for patients diagnosed with PJI, and how do we choose? There are several options. Tailored to the patient, the infection type, the organism, we can broadly categorize them.
Okay.
First, there's debridement with prosthesis retention, or DARE.
Keeping the original implant.
Yes. This is typically considered for acute infections, those developing relatively quickly after surgery, and for patients with a well-fixed implant and organisms sensitive to antibiotics.
What does DARE involve?
It involves an open arthrotomy, opening the joint surgically. This is strongly preferred over doing it arthroscopically.
Why not arthroscopy? Less invasive.
Less invasive, yes, but there's a more than 4-fold increase in treatment failure risk with arthroscopy. It offers limited visibility and less thorough debridement, especially for embedded biofilms.
So open is better for cleaning things out.
Much better. During the open procedure, you do a thorough irrigation and debridement, cleaning out all dead or infected soft tissue, removing any hematoma, evacuating pus. Exchangeable components, like the plastic liner and a knee replacement, are typically removed and replaced, as they're often heavily colonized.
What are the success rates for DARE, and what factors might predict failure, making it less suitable?
Success rates range broadly, maybe 31% to 82%. That tells you how sensitive it is to patient and infection factors. The goal is to salvage the implant, but it doesn't always work.
What makes it likely to fail?
Infection with Staphylococcus species, especially Staphylococcus aureus, is notoriously linked to high failure rates with DARE. They're just very good at forming biofilms.
Other factors.
Resistance to key antibiotics like MRSA, VRE, or fluoroquinolone-resistant gram-negatives, high ASA scores indicating significant comorbidities, compromised immune systems, a history of prior revision surgery on that joint, and, as I said, arthroscopic debridement all predict failure. DARE is best for acute, early infections with susceptible bugs in otherwise healthy patients.
And for staph PJIs treated with DARE, I understand there's a specific antibiotic regimen involving rifampin that's highly recommended. Why is rifampin so crucial?
Yes, the evidence strongly supports rifampin-based combination therapy for staph PJIs. It significantly increases cure rates.
Why rifampin?
Rifampin is crucial because it has excellent activity against bacteria in that sessile biofilm state. It penetrates the biofilm matrix much better than many other antibiotics.
But it can't be used alone.
Absolutely. Vital point. Never use rifampin as monotherapy. Bacteria rapidly develop resistance to it when used alone.
So always in combination.
Always. Rifampin is typically given with a synergistic intravenous agent like cefazolin or anti-staphylococcal penicillins for MSSA, methicillin-sensitive Staph aureus, or vancomycin for MRSA, the resistant strain, for an initial 2 to 6 weeks.
Followed by?
Followed by oral rifampin combined with a fluoroquinolone for a total duration of 3 months for hip infections or 6 months for knee infections.
Longer for knees. Why?
Likely due to the larger soft tissue envelope and overall complexity of the knee joint. If rifampin can't be used, the initial IV course should be at least 4 weeks. And for MSSA, drugs like cefazolin are preferred over vancomycin due to better activity.
Okay, next option. The one-stage arthroplasty exchange. What does that procedure involve, and what's the antibiotic plan?
A one-stage exchange involves removing all the infected components and immediately reimplanting a new sterile prosthesis in the same surgical setting,
All in one go.
all in one go. The advantage is sparing the patient a second major surgery, reducing morbidity and hospital time.
Mm-hmm.
But it requires absolute confidence that all infected tissue has been removed. That makes it a more challenging option for complex or chronic infections.
What's the typical antibiotic regimen?
Most commonly, 4 to 6 weeks of 5E antibiotics post-surgery, followed by 3 to 12 months of oral antibiotics, depending on the bug and patient factors. For staph infections, IDSA guidelines suggest a sequential program, often including rifampin, similar to DARE. Indefinite chronic antibiotic suppression is often used afterwards, especially for higher-risk patients.
And then what's considered the most definitive approach, especially for tougher cases, the gold standard?
That would generally be the two-stage arthroplasty exchange. This is considered the gold standard for PJI treatment, particularly for chronic infections, difficult-to-treat organisms, or when DARE has failed.
2 stages meaning 2 separate surgeries.
Exactly. At least 2 separate major surgeries, often spaced out over several weeks or months.
What happens in the first stage?
In the first stage, you obtain cultures from multiple sites, thoroughly debride all infected tissue, meticulously clean, and remove all prosthetic components and any old cement. This debridement is absolutely critical to get rid of the biofilm bulk.
And then what goes in the joint?
Following this, an antimicrobial impregnated PMMA spacer is typically implanted.
A temporary antibiotic-filled spacer.
Precisely. It serves a dual purpose, delivers high local antibiotic concentrations right at the infection site, and maintains limb length and joint space, preventing contractures and making the second stage easier. After this first stage, pathogen-directed systemic IV antibiotics are usually given for 4 to 6 weeks, based on those intraoperative cultures.
And then there's that crucial antibiotic-free period before the second stage, correct? What's the rationale for stopping antibiotics?
Precisely. A critical 2 to 6 week antibiotic-free time follows. This period is paramount. It allows us to gauge if the infection is truly eradicated. Any residual bacteria aren't suppressed by systemic drugs and become easier to detect. During this time, the patient is carefully evaluated for signs of ongoing infection, checking inflammatory markers like ESR and CRP, and crucially, doing another synovial fluid aspiration for cell count, differential, and culture.
What if infection is still present?
If there's persistent evidence of infection-high markers, positive cultures, a repeat debridement procedure might be needed, often followed by more antibiotics, before even attempting reimplantation. You have to ensure you're not putting a new joint into an infected field. That would almost guarantee failure.
So if the infection is deemed cleared after that waiting period, then comes the second stage, putting in the new joint.
Yes, if the criteria for infection clearance are met, then comes the second stage, the reimplantation. At this time, biopsy specimens are again obtained from the joint for frozen section, permanent pathology, and culture. It's a final check.
And if those are negative?
If those results are negative for ongoing infection, a new prosthesis is implanted, typically using antimicrobial-loaded PMMA again to provide ongoing local antibiotic presence. 4V antibiotics are usually continued until these reimplantation cultures are confirmed negative, just as an extra layer of protection.
Can you elaborate on those antimicrobial-loaded PMMA spacers used between stages? They seem vital, serving multiple functions.
They are indeed crucial, a really clever solution. They serve 2 key functions. First, mechanical support while the joint is out. This temporary structure helps preserve joint position, prevent muscle contractures, enhances patient comfort, and can even allow limited mobility between stages.
Are there different types? Static versus mobile?
Yes, we differentiate between static spacers, which just fill the space, and articulating spacers, which allow some range of motion. Articulating ones might offer better functional outcomes later, but the choice depends on the patient and surgeon preference.
And the second function, the antibiotics.
Secondly, and critically, they deliver high local concentrations of antimicrobials directly to the infection site. This augments systemic therapy while minimizing systemic toxicity, concentrating the drugs where needed most.
What antibiotics go in them?
The antimicrobials chosen must be heat-stable because PMMA heats up as it cures and water-soluble to diffuse out. Often 2 or more are included for broad coverage. A common effective combo is vancomycin plus an aminoglycoside, like gentamicin or tobramycin, at high doses.
High doses?
Significantly high doses, maybe 1 to 3 grams of vancomycin and 1.2 to 4.8 grams of aminoglycoside per 40 grams of PMMA. Generally, spacers should use a high dose, defined as at least 3.6 grams total antimicrobial per 40 grams of cement.
Is there solid proof they work better than just systemic drugs?
While widely used, robust data definitively showing that the spacers alone increase eradication rates compared to systemic therapy are still limited. There's a theoretical concern they could provide a surface for bugs to stick to, but until further data suggests otherwise, their mechanical benefits mean they remain integral to two-stage exchanges.
What are the typical outcomes for the two-stage exchange, and what might predict its failure? Even this gold standard isn't guaranteed, right?
You're right, no treatment is 100%, even the two-stage. The average success rate for infection eradication after two-stage knee revisions is around 83%.
That sounds pretty good.
It does, but you have to consider the significant selection bias patients chosen often have more favorable characteristics, and the concerning fact that the completion rate for the second stage is often below 50%.
Half don't make it to the second surgery.
Often, yes, either due to ongoing infection, medical issues, other complications, or patient choice. This profoundly impacts overall success stats. Success rates also vary by PJI stage, maybe 74% for early PJI, down to 49% for delayed, and only 44% for chronic PJI.
Chronicity really hurts the chances.
Dramatically. And certain organisms like Candida or other fungi are notoriously hard to treat and are best managed with this two-stage strategy or even permanent resection.
What predicts failure of a two-stage?
Reimplanting too soon, like within 2 weeks of resection, has a low chance of success, especially with S. aureus or gram-negatives, not enough time for clearance. Positive cultures from tissue or the spacer itself at the time of reimplantation are also strongly linked to later failure, regardless of symptoms. Inflammatory markers like ESRCRP aren't always helpful in identifying persistent infection at that point.
Beyond these main strategies, what are the salvage procedures? For patients who haven't responded or have life-threatening infections, these are last resorts.
These are indeed the last resort options for the most challenging scenarios where other strategies failed or aren't feasible. For patients unable or unwilling to get a reimplantation, resection or arthroplasty without reimplantation is an option.
Just take the joint out and leave it out.
Exactly. Remove the infected prosthesis and surrounding tissue, no new joint. The goal is infection eradication, often leaving a girdle stone type situation where scar tissue fills the gap. Antimicrobial treatment is typically 4 to 6 weeks of IV drugs. It clears infection but often leaves significant limb length issues and functional impairment.
And the most drastic options.
The most drastic are arthrodesis, joint fusion, and amputation, reserved for failed treatments or life-threatening infections needing urgent source control.
Fusion removes pain, but also motion?
Yes, arthrodesis fuses the joint solid. Amputation, while rare overall, maybe 0.1% of primary knees, is the ultimate failure. It occurs in 14% to 25% of patients who fail a two-stage exchange for knee PJI. These numbers show the severity and the desperate measures sometimes needed.
Is antimicrobial treatment alone without any surgery ever an option? It sounds appealing, but your points on biofilms make me skeptical.
You're right to be skeptical. Generally speaking, antimicrobial treatment alone is not recommended with curative intent. This is a critical message.
Why not?
While it might seem appealing to avoid surgery, this approach often delays appropriate surgical management and can critically complicate microbiological diagnosis by suppressing growth without killing the biofilm. The very nature of biofilms makes them highly resistant to systemic antibiotics alone.
So only in very specific cases.
Only for a very select group. Patients truly unable or unwilling to have surgery due to extreme comorbidities who have a well-fixed prosthesis are infected with bugs highly susceptible to oral drugs and, crucially, have a very early acute infection without a mature biofilm. It's a limited scenario, often more suppressive than curative.
And finally, what are the general guidelines for antimicrobial treatment across all these strategies? Tailoring seems key.
Tailoring is absolutely paramount. Antimicrobial therapy should always be pathogen-directed and meticulously guided by susceptibility testing results.
Once you know the bug and what kills it.
Exactly. Once you have that, the goal is the least toxic, most efficacious, narrow-spectrum regimen possible. This minimizes side effects and helps fight antibiotic resistance.
And requires monitoring.
Yes, for patients on prolonged oral or outpatient 5E therapy, regular lab monitoring is crucial, checking kidney function, liver function, blood counts for adverse drug effects. It's a long journey, and antibiotic management needs careful attention throughout.
This deep dive has really highlighted the immense medical complexities of PJI. But beyond the clinical challenges, PJI has such a profound, often devastating impact on the patient's life, extending far beyond the acute treatment. It touches every aspect of their well-being.
That's a crucial point, something we as clinicians must always keep front and center. PJI isn't just a local infection. It's a systemic illness with severe long-term consequences.
What kind of consequences?
Inappropriately treated or missed PJIs can lead to persistent infection with profoundly deleterious results, profound disability, severely impaired quality of life affecting every daily activity,
Worse than those with uninfected replacements.
significantly diminished life quality across physical, emotional, social domains compared to those with non-infected replacements, impaired joint function, much higher likelihood of needing mobility aids, assisted living, often losing independence.
And the numbers reflect this.
PJI is directly linked with prolonged hospital stays, like 7.6 days versus 3.3 days for a standard hip replacement. Suboptimal treatment outcomes, high disability rates, diminished life quality, and tragically, increased mortality.
Mortality, how much higher?
The 5-year mortality rate after hip PJI is a sobering 21%. That's a 4-fold increase compared to age-adjusted rates. And 10-year mortality can reach as high as 45%.
45%.
These figures underscore the severity. Early detection and aggressive management aren't just about saving a joint. They're about saving a life and preserving its quality.
Those mortality figures are indeed sobering. And even when treatment is successful, it sounds like patients shouldn't expect a normal joint back. What can we tell them about functional outcomes and the often long road of rehab?
You've hit on a key point for managing expectations. It's absolutely essential to clarify that surgery to treat PJI involves removing infected bone, often significant soft tissues. The expected outcome is not a normal joint like they might have had after their primary surgery.
So some lingering issues are common.
Many patients will have some residual discomfort, a persistent awareness of the joint. Range of motion or strength might be limited. We must be upfront and empathetic about this.
And rehab is even more important.
We must emphasize the critical role of post-op rehab. It will typically be much longer, more intensive, probably more painful than after the original surgery. Patients need immense commitment and patience, diligently following PT exercises for months, maybe years, to optimize function. Without that dedication, even successful infection eradication might not lead to acceptable function.
Beyond the physical, there's that significant psychosocial burden, isn't there? The journey with PJI is often long, isolating, emotionally taxing. How does this chronic condition impact mental well-being?
The psychosocial burden is indeed profound, and it needs as much attention as the physical treatment. Patients face a relentless cycle. Recurrent hospital stays, costly repeat surgeries, extended hospitalizations disrupting life, increased outpatient visits, prolonged, often IV antibiotics. These factors collectively culminate in dramatically reduced physical capability, periods of bed confinement, significant loss of independence, heightened fears of the disease worsening, or even mortality.
That sounds incredibly stressful.
To psychological distress, pervasive feelings of isolation, elevated depression, and anxiety experienced by PJI patients are, disturbingly, comparable to cancer patients. They often feel alone, facing a chronic, debilitating condition impacting identity, work, social life. The extended recovery, even when successful, induces significant strain, helplessness, despair.
And it affects clinicians, too.
And it's not just patients. Healthcare professionals, especially surgeons, can feel guilt, frustration, cognitive strain managing these cases, contributing to burnout. This is exactly why a holistic approach addressing mental health is so vital.
Given that immense physical and emotional toll, how can we empower patients and ensure they have the support structures needed to navigate this? What practical advice and services can we offer?
Patient empowerment is absolutely vital, starting with clear, empathetic communication and robust support. We stress the extreme importance of patients owning their health, physical and mental, before and after surgery. Reiterate smoking cessation, blood sugar control, they have an active role.
What about support structures? Managing 4-AT antibiotics at home.
A critical support structure is outpatient parenteral antimicrobial therapy, or OPAT. This vital service lets medically stable patients go home while still getting IV antibiotics.
How does that work?
Usually via a PICC line, a peripherally inserted central catheter. Arrangements are made for self-administration after training, family help, or nurse visits. OPAT hugely reduces the burden of long hospital stays, improves quality of life, lets them recover at home, and can cut healthcare costs.
Good follow-up.
Long-term follow-up is essential. Typically at least 2 years with the surgical team and infectious disease specialists to ensure the infection is truly cleared and monitored for recurrence.
What about managing concerns after discharge? Leaking wounds, pain?
It's crucial to give clear, actionable guidance. What to do if the antibiotic drip stops, if the wound leaks, if pain spikes, if a fever develops. Patients must know to contact their clinical team promptly for any of these. Stopping antibiotics early can wreck the chance of cure, and other symptoms might signal recurrence or complications.
And mental health support.
Finally, given the psychological distress, we must ensure patients know about and can easily access mental health support, psychological therapy services, counseling. Offering these resources isn't optional, it's integral to comprehensive care.
This deep dive has truly highlighted the immense complexity and ongoing evolution in managing paraprosthetic joint infections. It's clear it's a constant learning curve for the orthopedic community and for all clinicians involved.
Indeed. The last 2 decades have seen significant improvements in our understanding and management of PJI as a distinct condition. We've moved from a general approach towards recommending personalized treatment at specialized centers.
Like cancer centers.
Similar model, yes. It's becoming increasingly essential for PJI because of the complexity, the diverse surgical scenarios, the myriad bugs, the rising challenge of antibiotic resistance, all necessitate specialized, individualized, multidisciplinary care.
An integrated approach.
This integrated approach, orthosurgery, infectious disease, rehab, nutrition, mental health, is crucial for optimizing outcomes and ensuring access to high-quality care. We are getting better, but the fight definitely continues.
The battle against paraprosthetic joint infection is truly a testament to the complex challenges in modern medicine. As we continue to integrate advanced diagnostics, personalized treatment plans, and comprehensive patient support, what new frontiers in biomaterials, antimicrobial development, or perhaps host response modulation will truly redefine the future of PJI management for patients worldwide?